Hello, everybody, and welcome back to the main stage of the Concordia Africa Initiative event. We are so excited for the next hour of programming we have ahead of ourselves, and we hope you've enjoyed yourselves so far. I'm Kevin Wenzel, the Director of Global Programming for Concordia, and your MC for this event. With that, we're going to get right into our first discussion. This discussion is sponsored by Merck, and Merck has been a longtime supporter of Concordia for 2 years now, with their experts providing insights to our platform across our annual and regional summits. Their team of experts are here to share alarming yet hopeful outlooks into the rates of which HIV/AIDS impact women and girls across the continent and the work that the company is doing in collaboration with experts to address this challenge. Merck also elevated this subject at our recent 10th annual Concordia Summit through their partnership with UNAIDS, PEPFAR, and the Bush Institute. You can watch that video and other Merck programming on Concordia's website. And with that, I am so excited to welcome this esteemed panel, along with our moderator for this conversation, Dr. Jen Cates, Senior Vice President and Director of Global Health and HIV Policy at the Henry J. Kaiser Family Foundation. Jen, over to you.
Thanks so much. Hi, everyone. It's great to be here and to be here with this amazing panel to talk about one of the most fundamental challenges that we have in HIV, which is how to reach young women and adolescent girls to further progress in this epidemic. We're lucky that we have 4 amazing experts to talk with us about this. I'm going to briefly say who they are, and then we're going to get right to our discussion. We have with us today Dr. Roy Baynes, who's Senior Vice President and Head of Global Clinical Development and Chief Medical Officer at Merck Research Laboratories. We have Dr. Linda-Gail Bekker, who's Deputy Director of the Desmond Tutu HIV Center. We have Dr. Elizabeth Bukusi, who's the Senior Principal Clinical Research Scientist at the Kenya Medical Research Institute, KEMRI. And finally, we have Dr. Quarraisha Abdool Karim, who's the Associate Scientific Director at the Center for the AIDS Program of Research in South Africa, or CAPRISA. Hi, everyone. Thanks for being here. We have a lot to cover in a short period and actually some news today to talk about. So I'm going to start with Dr. Baynes to talk about a new announcement between Merck and the Bill and Melinda Gates Foundation, who announced a new collaboration today to advance a phase 3 clinical trial in HIV prevention. Can you tell us what this is and why it's so important and what we can look forward to on learning from this trial?
Well, thank you very much. Our collaboration with Bill and Melinda Gates Foundation and this phase 3 study exemplifies our shared mission to end the global HIV epidemic through meaningful innovations in HIV prevention, including additional PrEP options. Our drug islatravir is a very promising antiviral candidate with evidence from ongoing clinical trials to support its development as a once-a-month oral PrEP agent. This collaboration with the Gates Foundation will help advance HIV science and potentially offer a new option to prevent HIV acquisition among at-risk women, both in Sub-Saharan Africa and globally. TDF-based PrEP has not been shown to be nearly as effective in multiple trials in women as in men, and young women are at highest risk for HIV infection in Sub-Saharan Africa. If we are to address this need and help our 2030 goals be achieved, new drugs and new technologies will be required. Long-acting cabotegravir looks like a helpful new addition. We do believe that monthly oral islatravir could provide a new tool that addresses both clinical efficacy issues as well as implementation and programmatic challenges of daily oral PrEP therapy. Taking a daily oral pill for PrEP is often impractical for a variety of reasons and issues. HIV prevention options must seek to effectively address these issues. Attributes of islatravir include remarkable potency, long intracellular half-life, profound tissue penetration, and an excellent resistance profile. So we are very eager to get this phase 3 study underway and hopefully make a difference in this epidemic.
Thanks. That's exciting news. And keeping with that theme, you mentioned it as well. I'm turning to Dr. Bekker. Last week, we did get positive results from the trial looking at long-acting cabotegravir. Can you talk about that a little bit? What would we learn, and why is this so significant, particularly for potentially young women and adolescent girls?
Thanks, Jen. Yeah, this is really exciting. And the way that I think some people have described prevention, it's like a mosaic, and we're filling in the various pieces because our lives are diverse. We as people are all very different, including young women and girls. Different people have different needs. And I think what we've learned from contraception in this space of young women and girls is that if we give people choice, and they're able to adopt prevention methods to their lifestyles, that they actually are more likely to use those various modalities, and there's a broader uptake and adherence to modalities. So we know after 35 odd years that we aren't going to solve the HIV problem with treatment alone, and we're not going to solve it with only behavioral methods. We're going to need a nice mix of treatment on the one hand, because we know treatment is prevention, but also primary prevention, which includes biomedical technology. And for a very long time, all we had was the male condom. And so it's very exciting that really in the last few years, we've been able to add pre-exposure prophylaxis, particularly topical, such as the vaginal ring, and now, very excitingly, the injectable option, together with, of course, daily oral PrEP. And this means that young women now can choose what is going to suit them the best. And so for the first time, we can talk about not only who, and be specific. Is this for a young man, or is it for a young woman? Is it for somebody who, you know, has many partners, somebody who is in a monogamous relationship but needs some protection? So we can really get quite specific. We can also talk about what. So is it that somebody needs something short-acting and a daily PrEP agent, or do they need something less frequent? And this is where it is very exciting that we're now talking about vaginal rings, injectable agents that only need to be dosed every 2 months, and with the promise of the implantables coming, that actually that interval might even be longer. So really becoming an opportunity for us to talk about differentiated care in the truest sense of the word. We can now say, who is the client? How do we match what they need and make sure that we get that to them? There are some implications. Obviously, how we distribute is also going to be very dependent on what it is that we're distributing. And we're just coming to terms with that now with oral PrEP. Obviously, the injectables and the implantables bring a whole slew of new challenges, but I think we're really up for that. I think in this era of differentiated care, it is possible to get these various modalities to the people who need them most. And I think it has exploded primary prevention in terms of it really is a revolution. Thanks, Jen.
Thank you. Thank you. So I want to turn to Dr. Abdool Karim to talk more about what this actually might mean in terms of your research and what you know about the complexities facing adolescent girls and young women in their lives. And you've written so much about the nexus of science, advocacy, and policy, and how we have to understand that their relationships to really make change. Given the challenge that we're faced with, that more than half of new infections, HIV infections globally, are occurring in Sub-Saharan Africa, and women account for the majority of those. How do we pull this together? How do we take these advances that are so exciting, and finally, you know, we're seeing maybe an acceleration, but how do we realize them?
Thanks very much, Jen. So let me just start with this nexus between science, activism, and policy and practice. So in the public health space, what's really important is that we ensure that our scientific advances get to those who need to benefit most, because just generating new knowledge without access to the beneficiaries, in my opinion at least, is meaningless. And I think in our response to HIV, we have learned how important evidence-based advocacy is. And it goes back from the early days of our response to HIV, where we've seen how activism really pushed the boundaries of scientists and even removed obstacles like regulatory ones. And we've seen with PMT-CT and with ARV treatment, for the first time, there is no difference if you have AIDS, what drugs you put on. And that didn't happen by accident. It happened by very close working together between scientists, between advocates, and ensuring not only that we get policy in place, but the right investments are made through multiple mechanisms to make that happen. In the context of HIV prevention for women, I think it's taken us a long time as a global community to recognize that there is a big gap between where our burden of infection is and what is available for prevention. And I think the use of antiretrovirals prophylactically was, and the first proof of evidence, both from the gel and subsequently from daily use of tenofovir with emtricitabine, really opened the path, I think, for several things. The first is greater industry involvement for women-initiated technologies. And I think this daily pill in the context, monthly pill in the context of COVID-19, where we're having competition for health system access and essential services being compromised, a monthly pill and 12 pills in a year compared to 365 could be a real game changer, in addition to some of the other technologies that Linda-Gail mentioned. So what we need for women, given their diverse needs, is a wide range of safe and efficacious products that women can choose what matches what their needs are. And I think when a lot of the focus has been on less user-dependent technologies with the injectables, etc. So this monthly pill, I think, is going to be a very interesting development in terms of how do we link behaviors with products that potentially could work. I think we still will need a vaccine. But I think an important gap in terms of technologies is understanding the biology that underpins the vulnerability of women, because it is a combination of behavior and biology. And we know that in the behavioral part, that adolescent girls and young women acquire infections, certainly in Eastern and Southern Africa, in age disparate relationships. And having tools that they can use that don't require cooperation from their male partners who are 5 to 7 years older than them, and to have the rights and agency to keep themselves negative. And in a continent where young people under the age of 35 is our demographic dividend, could be really a major game changer in terms of enabling women to reach age 21, 22, HIV-free, and hopefully with integration into sexual reproductive health services, also stop and prevent pregnancy. So I would like to close with two final points. And I think that one of the biggest challenges we've had in this very exciting changing PrEP landscape that includes ARVs and broadly neutralizing antibodies is that we have been shy of including young women.
Hi, everybody. Sorry about that interruption. You know, we have some technical difficulties with these digital events, but we are back. We have all of our speakers with us. And so we're going to jump right back into our conversation. So Jen, I'm going to turn it back over to you. Sorry about the interruption.
Hi, everyone. Okay, well, it's COVID-19 times, and we're all doing what we can. So I don't know how much time we're going to have left, but I want to go to Dr. Bukusi to let her join us in the conversation now. We have about 10 minutes left, I've been told. So just Dr. Bukusi, you are a principal investigator on the Empower prevention studies that we're hearing about, which Merck is conducting in collaboration with the Gates Foundation and the University of Washington. You were also one of the investigators on the ECHO trial that found an ongoing high level of HIV infection in young women in Sub-Saharan Africa. So clearly young women are the population that is most at risk of being infected and faces some of the challenges that we started to get into in terms of interventions reaching them. Can you share with us your insights from the ECHO trial and the work that you're doing now on how to address the challenges that young women in particular are facing that put them at increased risk? Thanks.
Thanks, Jen. Well, I'd just like to say that both Linda and Quarraisha have really made really important observations. And you've just added to it, saying just how much at risk young women are. And having worked in the field of medicine for the last, now I'm counting a good 35 years, I must say that it's been a very distressing thing to see young women continually get infected. And as an obstetrician gynecologist, this is one of the things that made me start working in the field of HIV. Just looking at the young women who are getting infected and they didn't have options in the early years. As you've rightly asked, young women are at risk. But you know, the sad thing is that something like HIV doesn't worry them in the same way something like pregnancy does. Because pregnancy is something that's short term. They figure out they're pregnant, they need to do something about it, they're panicking. It's something that starts to show. HIV, one could get infected and not be aware, not get tested, not be concerned. And so there are many young women who will worry more about getting pregnant than getting HIV. So it's important that we really leverage in the places where they're already going to perhaps look for options, when they recognize that they need to have comprehensive ways of dealing with their sexual and reproductive health needs, that we can meet them at that point in time and be able to provide them with solutions. Quarraisha said this, and I can't overemphasize it enough. We are not talking about a one-size-fits-all. There isn't one solution to every single person. And Linda-Gail also mentioned it's a mosaic. It's different young women in different stages of their life with different needs, and we need to be able to attend to this. So indeed, this may be a welcome change. For some, an injection may be what works. For others, it could be a pill. For others, they may need something different. But indeed, as we've learned from supermarkets, the more options you give some people, the more likely it is that someone will find something that works for them, that does make a difference, that meets their needs in that niche that they occupy. What have we learned from ECHO? Many things. And we have learned from the early studies that have looked at just providing daily ART for HIV prevention. The concern is sometimes people start with enthusiasm, but keeping on with it, taking a pill daily. And we know this even from those who have chronic illnesses. It's not easy. Our lifestyles may not necessarily make it possible for people to be able to take a medication every single day. They may not have the space. Where are they keeping it? At what time do they take it? Can they keep taking it every single day? So providing options like an injection, which you can go and get. And we know one of the reasons that depot injections have been very popular in Sub-Saharan Africa. It's discreet, you take it and then you don't have to take it again. And maybe a pill will also offer that. You only take it once, and then you don't need to think about it again for another whole month. I wouldn't say we've learned everything. I think we still need to learn some more. How do we make it possible for the agency that Quarraisha talked about to enable young women be able to make choices that allow them to live to their fullest potential without the worry and the threat about the outcomes of getting HIV infected? And that's what will give us a generation of children that will be born HIV-free.
Thank you. Oh, go ahead. Did you want to say something else?
No, that's really the emphasis that I wanted to be able to make, that we do need to be able to give, because you can imagine that a young woman whose life is changed, one, by pregnancy, or two, by HIV. The question then becomes, will they ever get to reaching their fullest potential and being able to provide and be productive as a member of that society who can give back? It really does make a difference for them. Over to you, Jen.
Thank you. So one of the issues that has come up in some of the comments is the sort of connection between the HIV prevention and reproductive health and family planning, both in terms of lessons that we can learn around method mix, but also around the needs that we know that young women face and the things that they're looking for. So how can we do a better job of bringing these technologies and these interventions together for young women? Linda-Gail, I'll start with you on that question.
Thanks, Jen. Yeah, really huge. And I think Elizabeth sort of just hinted at it, that young women, their lives are busy. They have a lot to think about and a lot to do. And so bringing services together that matter the most to them in one place is really, I think, something we can contribute that could mean a lot for them. So the one way we can do it is co-locate them. So make sure that when we provide PrEP, there is also contraception and sexual health, services right there. Even more exciting, we can co-locate the ingredients in a single intervention. And this is the way of the future. And young women have said to this to us so many times. If only I could, have the contraception and my HIV prevention all in one go, or, have my STIs managed along with my HIV prevention. It makes a lot of sense. And as we've seen the interventions that have come through in the last few years, I think we've got more and more confident that it's going to be possible to co-locate contraception and STI and HIV prevention agents in the same kinds of interventions. So think of a ring that might be able to do more than one thing, or an injectable that, at the time you come for your injection, you would also get the other needs met. Now with a monthly pill, it's possible for us to think about how we co-locate contraception, sexual health needs, and HIV prevention. So I think we're finally beginning to hear what these young women have been telling us for decades. And I think we're finally being able to produce what they need. Over and out, Karim.
Thanks. Does anyone else want to comment on that point? Quarraisha or Roy?
Sure, I'm happy.
Go ahead, Quarraisha.
Yes, go ahead. We have a couple minutes left, so yeah.
Well, I would just say, as a company which has put a lot of effort into contraception, you may be aware Nexplanon is one of our devices. And we have already actually looked at some phase 1 data where we've put the islatravir molecule into a Nexplanon type of implant and demonstrated that we can maintain adequate therapeutic levels for over a year at a time. You could imagine that it might be not too much of a reach to try and put the contraceptive agent together with the antiviral into the implantable. And that's a project which is in its early form, but certainly offers great promise.
Thanks.
So Jen, I just wanted to add that I think that not all sex in young people is by consent. And we have a lot of gender-based violence there. We've seen it again with COVID-19. And I think that policies, for example, that restrict comprehensive sexuality education is where things start, need to be addressed. And in addition to, technology is an important starting point, but they don't reach to the fundamental gender power imbalances that exist and who shapes this agenda. And I would really encourage us, as we start to address it and use the opportunity of working with young people, to appreciate the importance of basic education, to appreciate the importance that young people, we're dealing with a whole new generation of young people. It's at a time in their lives where peer influence is much stronger than with adults or even parents. And so the technologies offer us opportunities to break open the space, to ensure that young women's lives have meaning and are worthwhile. And that's what I look forward to, that as we develop these technologies, it's a first step, but it does not take us away from the fundamental issues around gender inequities that persist globally.
Thanks. Before we're about to wrap up, but Elizabeth, I just wanted to turn back to you and see if you had wanted to add into that conversation that we're about this issue that you raised.
I think it's been said beautifully, and I would really just say I think this has been said in many different contexts. If you do provide education and you empower a woman, you're empowering a whole village. It's not even just a family.
Thanks. Roy, I just want to come back to you since we started with the talking about the announcement from today. Can you tell us a little bit more about what the timeline is, what we should expect, and also what are the challenges of developing new PrEP technologies more generally?
Yes, so our phase 2 data we have already presented, and they look very encouraging. The trial will be getting underway very rapidly in Africa, and we're partnered, as you heard, with the Clinical Trials Research Group out of Seattle, right. University of Washington. In parallel, we're also obviously looking at this approach for men who have sex with men. That will be largely a North American-based trial, and that trial is also set to get underway. The challenges of these trials obviously are the complexity and size, and we are very fortunate to work with experts in the field who have a lot of experience conducting these trials, and so we're eager to collaborate. And we do believe that these types of approaches will become pretty meaningful in extending the possibilities of PrEP. Time horizons here obviously will depend upon trial conduct, and there is a little uncertainty about trial conduct at the moment in the face of the COVID pandemic, where it's not quite as easy to move around and activate sites and monitor sites and, as it was previously. But we've been able to keep the wheels turning, and so we're optimistic that this trial will get done in expeditious time frame.
Great. So for my final quick question to answer, just a yes or no or maybe to each of you, if you look ahead 3 years or maybe 3 to 5 years, do you think we're just going to be in a sea change for young women and adolescent girls on HIV prevention?
Yes.
Okay, Roy says yes. Quarraisha?
Yes, and about time, I'd say too.
Linda-Gail? Oh, come back on, you're on mute. We want to hear what you said.
I'm saying I'm depending on it.
Great. And Elizabeth, you have the final word on that.
Absolutely, and it's a commitment we must make to the next generation. We don't have an option.
I agree. Terrific way to end this. Thank you, everyone, and exciting to hear that we're moving in the right direction, hopefully. So thanks for being here today.
Thank you.
Thanks.
Thank you.
Bye. Bye, everyone.
Thank you, Jen, and thank you, everybody. What a powerful way to end on that positive note, and challenging everybody to make that happen. And thank you to Merck, as always, for sponsoring that conversation.